Good afternoon. My name is Hermann Einsele. I'm based in Würzburg in Germany, and we run a quite bit myeloma and also immunotherapy program. So we have been treating patients with CAR T cells and T cell engagers directing BCMA, but also GPRC, 5D, and SLAMF7. And we have seen very nice responses with CAR T cells and bispecific antibodies, but with both treatment modalities, CAR T cells and T cell engagers, we see quite often some CRS and some neurological toxicity, which unfortunately enough is not very severe in most of the patients with multiple myeloma, but in about 3 to 5%, we see grade 3 CRS and neurotoxicity. So what can we do to prevent it or to mitigate it? So one question is, what are the high-risk patients? And what we know is that potentially elderly patients, patients with a high tumor load, patients that already have acquired severe CRS, and also patients with a high CAR T cell expansion and persistence are patients at high risk to develop severe neurotoxicity. And there is, with one product, also this kind of late onset neurotoxicity, which is often Parkinsonian type. For this product, a specific prophylactic and mitigation strategy was developed. So in any patient who was at a higher risk to develop this kind of neurotoxicity, an intensive analysis of handwriting, neurocognitive function was performed, and actually doing this and early interfering was extremely successful to prevent this severe and late onset neurotoxicity. And that has now been shown in more than 100 patients receiving the cilta-cel product. So I think, first of all, neurotoxicity is fortunately not very frequent in patients receiving CAR T cells for multiple myeloma, but with this new risk stratifying strategies to really define patients at high risk and to really screen for early neurotoxicity, I think for most of our patients, we can really prevent severe neurotoxicity.